Assalamu alaikum and Eid Mubarak to everyone. Let me start with the simple question. Why do patients take painkillers like aspirin or NSAIDs? Or NSAIDs develop gastric ulcers? What exactly is being disturbed at the biochemical level? Today, we are going to unpack the mechanism in a very structured way by understanding the role of prostaglandins in gastric secretions. By the end of this session, you should be able to define prostaglandins and eicosanoids, understand how they are synthesized, explain their role in regulating gastric acid secretion, and most importantly, connect this with real clinical scenarios like NSAID-induced ulcers. So this is not just theory. This is clinically actionable biochemistry. Let's start with the introduction to prostaglandins. Prostaglandins are part of a large family called eicosanoids derived from a 20-carbon fatty acid, arachidonic acid. This family includes prostaglandins, thromboxans, and leukotrienes. Now, here is the key idea. Prostaglandins act as a local hormones, also called autocoids, right? They don't travel in blood like endocrine hormones. They actually act exactly where they are produced. Let's quickly understand what makes prostaglandins unique. They are produced in almost all tissues. They are not stored, they are synthesized on demand. They have a very short half-life and they act locally. This means their effects are rapid, localized, and tightly regulated. From an exam point of view, this is classical differentiation from true hormones. Structurally, prostaglandins have a cyclopentane ring with side chains. Different prostaglandins like prostaglandin E, prostaglandin F, prostaglandin I vary based on substituents. You don't need to memorize all structures, but you should recognize that structural variation leads to a functional diversity. As you can see on the screens, this is this illustration showing the various type of prostaglandins, right? Now, let's move into a most important biochemical pathway. Everything starts from membrane phospholipids. These are acted upon phospholipase A2 releasing arachidonic acid. Then comes the key enzyme, cyclooxygenase, COX, COX, cyclooxygenase. This converts arachidonic acid into prostaglandin G2, then prostaglandin H2, and from prostaglandin H2, different prostaglandins are formed. Now, let's discuss the cyclooxygenase pathway, the central player. This enzyme, cyclooxygenase, is critical. There are two forms of cyclooxygenase enzyme. COX-1, that is protective and physiological in action, right? COX-2, inducible and inflammatory in action. Now, here's the clinical punchline. COX-1 is responsible for maintaining gastric mucosal protection. If you inhibit COX-1, you compromise the stomach lining. Now let's discuss the inhibition of prostaglandins. And let's connect this to the drugs. NSAIDs, like aspirin, inhibit cyclooxygenase. Corticosteroids act even earlier. They inhibit phospholipase A2. So what happens actually? You block prostaglandin synthesis, and when prostaglandin decreases, you remove gastric protection. This sets the stage for the ulcer formation, the ulcers. Now we come to the heart of the lecture, the role in gastric secretions. Prostaglandin, especially prostaglandin E2 and prostaglandin I2, plays play a protective role in stomach. They actually decrease acid secretion, increase mucus production, increase bicarbonate production, improve mucosal blood flow. So overall, they act as a gastric protectors. Let's go one level deeper by discussing the mechanism or the acid inhibition. Prostaglandin act on parietal cells. They decrease intracellular CAMP levels. And since CAMP, cyclic AMP, is required for acid secretion, its reduction leads to decreased hydrogen ion secretion. So prostaglandin directly suppresses gastric acid production. Now let's discuss the another mechanism, mucosal protection. Beyond acid inhibition, prostaglandins strengthen the defense system. They actually increase mucus secretion, increase bicarbonate, and maintain epithelial integrity. Think of mucus and bicarbonate as a protective gel layer over the stomach lining. Without this layer, acid would damage the mucosa immediately. Let's discuss the defense versus aggression model. The stomach is constantly balancing two factors, aggressive factors and defensive factors. Aggressive factors include HCl, hydrochloric acid, and pepsin, while defensive factors are mucus, bicarbonate, and prostaglandins. If defense weakens or aggression increases, you get ulcers. Prostaglandins are central to maintaining this balance. Now, let's correlate with the NSAIDs. And we can connect everything with it. A patient takes NSAIDs regularly. These drugs inhibit COX, cyclooxygenases, that decreases the prostaglandins. What happens eventually? Less mucus, less bicarbonate, and more acid damage. And the resultant would be gastritis and peptic ulcer. This is one of the most frequently tested clinical integration in exams. So you need to correlate NSAIDs with the formation or the breakdown of the mucosa to produce ulcers, right? To cause ulcers. Actually, NSAIDs inhibit the COX, that decreases prostaglandins, and the resultant that leads to less mucus production, less bicarbonate production, and more acid damage. And the resultant would be gastritis, ultimately lead to peptic ulcers. As I mentioned earlier, this is one of the most frequently tested clinical integration in exams. Let's discuss the therapeutic use of prostaglandins. To counter this, we use misoprostol, a prostaglandin analog. It mimics prostaglandin E and restores mucus, bicarbonate, and protection of lining. So in patients, On chronic NSAIDs use or usage, misoprostol helps prevent ulcers. This is one of the applied pharmacological biochemistry. Now, integrate this with what you already know. Acid secretion is stimulated by histamine, gastrin, acetylcholine, or vagal stimulation. Prostaglandin oppose all of these. So they act as a brake system in gastric physiology and biochemistry. Let's consolidate. Prostaglandin decrease acid, increase mucus, increase bicarbonate, and increase blood flow. And the final outcome would be protection of gastric mucosa. Consider this case, right? Let's discuss a clinical scenario discussion, right? Move to clinical discussion scenario. A patient presents with epigastric pain after prolonged NSAID use. Ask yourself what pathway is inhibited. That would be COX, cyclooxygenase pathway. What molecule is decreased? The answer would be prostaglandins. What is lost? The answer would be gastric protection. This is how you connect biochemistry with clinical medicine. Let's briefly discuss the other functions. Prostaglandins also play a role in inflammation, pain and fever, renal function, platelet aggregation. But for today, our focus remains on gastric, biochemistry, and physiology. If you remember only four things, remember these. Prostaglandins protect the stomach, they inhibit acid secretion, NSAIDs block prostaglandins, and the loss of prostaglandin leads to ulcers. So, next time you prescribe or take a painkiller, remember behind that small tablet lies a biochemical trade off relief from pain, but at the cost of gastric protection. Thank you very much for your attention.